Duncan, hi. You're the lead ePMA prescriber or pharmacist involved in electronic prescribing at the Plymouth University Hospital's NHS Trust in the UK. So your role is a little bit different from the classical clinical pharmacist. You're actually involved in the whole rollout of electronic prescribing throughout the hospital. Let's start with a very kind of introductory question about how do you see the role of digitalization in the whole medication management process, and your maybe observation of the medication-related patient safety from the past to today.
Sure. Okay. Tasha, so I come straight from a conversation actually with the lead for our acute pain service, talking about how we've introduced systematization of prescribing for high-risk medicines post-operatively. We've introduced a whole range of order sets within electronic prescribing to try to standardize prescribing so we get good quality of patient care, but also to improve patient safety. A lot of these medications are opioids or other high-risk medicines, and by using technology we can make sure that the prescriptions for those are correct and safe and clear, and also we can monitor those and report on those far easier than we could do with a paper system. So that's an example of how things are starting to transform for us, having adopted an electronic prescribing solution.
Just one thing, since you mentioned, order sets, can we just briefly explain, what order sets actually are and how much do they help prescribers? Is this something that is prepared by pharmacists so the doctors can rely on those prescriptions without having to think on their own what they want to prescribe to a specific patient? So just like a brief explanation of
Sure.
how they are helpful to prescribers.
Yeah. Okay. So an order set is a means of creating an almost complete prescription, rather than a prescriber having to decide they want to pick a drug and then decide on what dose, route, frequency they want, and any other additional information they might need to go into that prescription. They can make a request for a standard prescription, which within our team managing the electronic prescribing solution, we can then create that as a complete prescription, and it then means that a prescriber can select that whole data set with one click, and then prescribe that for the patient. So we take out the risk of them misselecting the incorrect dose or frequency.
Mm-hmm. Okay, thank you. I kind of interrupted you there in the middle, of the explaining what patient safety related to medication means to you, and maybe I just want to add one more thing to this question. It's quite hard to really assess what is the number of deaths or long-term consequences that are caused by medication-related harm, though there was a relatively recent research in BMJ Quality and Safety that kind of estimates that 237 million medication-related errors happen in the UK every year. 3 out of 4 are not serious, and but like in general, they still result in 1,700 deaths. So I just wonder, how do you see the development around medication safety? Is it improving? Is it staying the same because of various new factors that are coming in the care and increasing number of medications that are available?
I mean, certainly the transfer to digital medicines prescribing and administration takes away some of the long-standing risks around illegibility of prescriptions, around the need to transcribe from one prescription to another. And it makes the prescriptions more accessible, easier to review, easier to look at in a what's the word I'm thinking of? The kind of big data approach. So we can look both actively and retrospectively at prescribing to try to identify identify areas where we can improve. So that's definitely a big improvement. That said, technology does bring its own errors. So we're seeing perhaps some different errors, largely around a lack of familiarity with process. So we've changed what we were doing before, and there were perhaps some consequences of that we hadn't foreseen. Also,
Do
I
you
think
have
that
an example that you can share?
So for instance, with a paper prescription chart, you can see at a glance up to 10 days history of medication admissions and prescriptions, whereas depending on how you have your default user interface for an electronic prescribing system, you may only see 1 day or 3 days, and there may be key information that was easily visible in the paper format that would influence how you would behave, either prescribing wise or administration wise, that you don't see in the electronic system, and that can then potentially lead to problems with themselves. I think another aspect where perhaps there are new errors introduced is where things like there is an over-reliance or an over-expectation on what clinical decision support can offer. There's kind of an expectation among some users that the system will stop them making a mistake, and this is something that we have to very emphatically try to get across to new users in training, that they cannot afford to devolve responsibility for patient safety to the system. They are still ultimately responsible as the prescriber or the person administering.
And how is that working out? How does the training of people to be able to really kind of be mindful that the machine doesn't know everything, how does that work out in practice? Because on one hand, there's this huge hopes how AI is going to solve so many things, and I have an impression that we're now slowly going in the second phase of healthcare IT development, where if now we know what's not really working in healthcare IT, solutions such as indication-based prescribing, or solutions such as giving recommendations for prescribing based on data in the electronic healthcare record are coming to the market. And when a system is incorporating a lot of data, it's getting increasingly harder for the prescriber to really think of everything that the machine is thinking on. So to a certain extent, it's understandable that at a certain point the prescriber just relies on the system. So how do you bridge the gap, between kind of pushing away the responsibility and kind of making the system useful for the user?
I mean, from a training perspective, it's really quite difficult. A lot of the end users see training as a necessary means to an end, so they just need to get through it so they can start using the system, and not all some of the more subtle points that you're trying to get across necessarily persist when they finish that training session. So kind of some of it is around continual reinforcement rather than initial training. But certainly something that I'm quite keen to make sure that we don't lose sight of is the fact that practice is messy, and this is something that's certainly come up a number of times when we've been looking at some of the limitations of a digital solution. The way the system is going to handle those situations is dependent on the data, the information that you give it in the first instance, and sometimes life is just a bit too complicated. There are definite advantages from systematizing where we can, but it's important not to lose that kind of that human, both the contact in terms of the patient and the wider team, but also Douglas Shern talks about technical rationality versus professional artistry when talking about professionalism. So the technical artistry is like going through a set of standard processes to get to an end point. So by following those processes, you will get to the end point correctly. But it doesn't allow for the messiness of human life, of healthcare. Things don't always follow in the order that you think they're going to follow. There are some unforeseen interactions with the process, and that's where the human being, I think, is still required, and that comes through experience. So the experience and the ability to apply learning from one setting, one context to another context, being able to see similarities that you wouldn't necessarily be able to do from a digital solution initially, I think is still key. And that's one of the messages that I'm still keen to get across to users, is that they have to still think as a professional, and not to try to devolve any of that responsibility to the system.
You're actually also an educator, so you teach future medical students, right? So,
That's right, yeah.
you know, from the perspective of the younger generations being more digitally savvy, how do you see that either the training for them is changing, or the mindset of how they are using the technologies when they reach clinical practice?
There's certainly a hunger for it. We've just started piloting some use of our prescribing solution with our final year medical students. They're seeing it used in the clinical workplace on their placements, but are currently not able to use it in that environment. So we've now had the benefit of being able to use that in a classroom-based teaching session. And they love it, and they also seem to pick it up extremely quickly. They do seem quite intuitive users, and one of the things that's quite fascinating is looking at how they the kinds of data that they access online in sort of whilst they're trying to make prescribing decisions. They're very, very astute at how they're using IT and their search skills. So yes, it is quite a contrast to perhaps some of the more experienced clinicians that we've worked with, who are, I think, quite intimidated or frustrated or scared by technology, certainly when it comes to prescribing, where they've had maybe 20, 30 years experience of always writing on paper. But I think, as you're sort of possibly implying, the sort of ubiquitousness of technology now in all aspects of life means that our up-and-coming medics, pharmacists, nurses are all a lot more comfortable with the idea of technology being part of what they do on a day-to-day basis.
Yeah, and they're often also quite disappointed if they end up in the clinical practice and just see that they need to do so many things through the old ways or by hand, and I guess bureaucracy is something that is frustrating many people. So I don't know, it's you recently alluded to kind of published a link to an article that was explaining how daunting it can be for medical professionals when technology doesn't work, and I think that's especially interesting in the medication management space, when you can have like a completely automated system with you need those robots basically bringing the medications from the pharmacy, but it's maybe that robot then doesn't open up, or there's passwords and all sorts of challenges. I don't know, like to which extent do you see that those issues are present? Are they more of an exception?
I guess from our experience locally, we've perhaps still got quite a way to go on that kind of journey, but what I'm very mindful of is just trying to make sure that those end users are involved in the decision making, rather than strategic decisions being made without the actual people that will be using the systems having a say, and maybe enabling us to deliver a better implementation, because we're kind of seeing the system from the user's point of view, rather than just trying to get it done and move on to the next thing.
Mm-hmm. And if we kind of look at the broader picture, of medication-related patient safety, based on your experiences in the clinical practice and implementing technologies in a hospital setting, where do you see that most progress needs to be made, speaking generally?
Okay, so for me, continuity. So the interoperability of primary and secondary care systems. So the fact that we've got primary care that have been using digital for decades, and hospital, to a greater or lesser extent, is still relatively new to the game. The fact that there's still, even with some of the more advanced systems, the ability to share data across environments is incredibly limited. And it's a massive barrier to care. One of the big wins about introducing a digital solution is to try to minimise the need for transcription, so from one paper document to another. But until we've got really good integration systems created between separate digital systems, that transcription process is still required. So we're still relying on a human being having to translate one data set into another data set, and yet the information is exactly the same between the two systems. It's just that there's no means of communicating directly.
Yeah, I can now offer you, some of the thoughts that kind of came to mind or were mentioned by other speakers. So, yeah, transcribing errors if you're working on paper are definitely a huge issue, and eligibility. But then one thought that was interesting to me was when a clinical pharmacist from the US said that obviously polypharmacy is a challenge. People taking 5 or more medications, when you come to the number 5, there's probably something that's not going to work in favor to the patient in terms of either how he's feeling, or there's going to be another interaction. And the challenge is not, it is that the patient is taking many medications, but it's also that he's visiting multiple specialists, and no doctor is going to change a prescription for another doctor. So that's kind of where the clinical pharmacists can come in to kind of optimize just all the prescriptions. So maybe a thought from you there. What are your experiences in terms of changing prescriptions, and how do all the involved specialists get a message about the changes for a specific patient, so when the patient goes from the hospital to the home setting, his medications are not changed again to the state before the clinical pharmacist kind of optimized the situation?
That's certainly the kind of thing that we're wanting to try to establish, and I think we're making some inroads to that already. There is that need for someone to kind of be in the pilot seat for that patient. So rather than just focusing on specific aspects of care, like how different parts of maybe a plane are responding, someone has to look at the big picture, and whether that is the general practitioner, a clinical pharmacist. That, I guess, that role is yet to be defined, or that it may change from setting to setting. I think there are some clinical specialties, certainly in secondary care, that are better and braver and perhaps more experienced at this concept of deprescribing or medicines optimization. We see it particularly with our healthcare of the elderly physicians, where polypharmacy is obviously most prevalent. And I think because deprescribing is part of their day job, they're a lot more confident in making those changes than if the patient came under, say, another medical specialty or a surgical specialty, for instance. We are also trying to establish better links with community pharmacy, so that the messages that perhaps we're trying to get across to patients, or the slight refinements that we're trying to make as pharmacists, gets reinforced in the community, and changes are followed up. So rather than having to have an outpatient appointment, say, or a GP appointment, that the community pharmacy, who's going to be in contact with that patient on a regular basis anyway to supply their medication, can actually follow up and make sure that we're not getting outcomes that perhaps we weren't expecting.
Mhm. And just for a broader understanding, because the audience of the podcast is global and it's interesting to compare how things work in different countries, can you explain a little bit to which extent are clinical pharmacists involved in managing or checking prescriptions in the hospital, and to which extent in the community? So, are clinical pharmacists also available to GPs? Is there an established relationship that, I don't know, pharmacists in the pharmacy are in contact with the doctors to make maybe some consultations if they feel that a prescription is not accurate or appropriate for a physician? So just kind of the general state in the UK.
Okay, so pharmacist integration with clinical teams, there are some geographical variations, but it's been certainly a part of clinical pharmacy since I've been in practice, so that's quite a long time. But with primary care, we're now seeing certainly a big input of clinical pharmacists into GP surgeries, both looking at the individual patient care, but also looking at their sort of their practice population as a global population, and trying to influence prescribing and patient safety in that respect. And there are now better ties with those pharmacists that are working in community. They're sort of dispensing pharmacies in the community sector. So there is a role to be had by pharmacists in all sectors now, I think, in the UK, in optimising medicine's use for patients and maximising patient safety.
Mm-hmm. And is there an example that you could share, from your own clinical practice of a medication-related error that happened? Can you think of any examples that you thought were like really?
Yeah, I mean, so we had I remember when I was a junior pharmacist, or relatively junior pharmacist, we had a patient who had been admitted to hospital, had a diagnosis of rheumatoid arthritis, was started on weekly methotrexate, was discharged to the community. The GP wrote a prescription for daily methotrexate. The community pharmacy dispensed that prescription. The patient took it for about a week, came back into hospital with essentially bone marrow failure, and in spite of trying to use various rescue therapies and supportive therapies, the patient actually died. So yeah, there are. I've seen some very serious medication errors in the past.
So was that an error or just the way the patient reacted to the medication?
It was a prescribing error, so there was a failure to identify the correct frequency of prescribing for the methotrexate. So it is a potentially very toxic therapy, but it's a gold standard in a lot of autoimmune conditions, because it's so effective. But it's crucial that the patient only takes the medication on a weekly basis. And I think in a lot of prescribing, the default, prescribers will often go into kind of like an autopilot mode, and people tend to think about medications being given once a day, twice a day, rather than once a week. And we still see that, even though the NHS has taken a number of steps to try to minimise the risk of that since I saw that patient. It's almost impossible to completely eradicate the risk of that error.
Mm-hmm.
And that's even with having clinical decision support systems highlighting alerts to prescribers.
Mm-hmm. Yeah, that's kind of when it comes to alerts. I'm hoping, just from the patient safety perspective, that new systems are going to be better at that. There are, as I mentioned before, I feel that we are now entering in kind of the second age or century of these decision support systems, where a prescriber is not going to get 1,000 alerts and then ignore them all, but really get more specific and useful alerts, because it's based on the example that you mentioned, it's quite hard to imagine that a thing like that can't happen today, even if with digital systems. If somebody overrides an alert, like that could still happen.
Exactly, and we've seen a patient bring in a prescription for the same medication that had been generated on a GP system, which would have almost certainly have had numerous alerts, but the patient was still prescribed a daily dose of methotrexate, which, had they taken, would almost inevitably have been fatal.
Hmm.
Um, so yeah, I think because and you don't want to necessarily put hard stops into systems, because you need to have, again, that kind of the human ability to cope with the messiness. There are always exceptions to the rules, and so it's important to enable that kind of individualisation of care, but at the same time, there's potentially a tendency to not pay that much attention to alerts, and to just try to get through the work as quickly as possible. And it's trying to manage the tension between those two, I think, that's really crucial.
Hmm. Are you seeing that the patients are changing in the way they approach healthcare? In the last 10 years, the approach to partnership is kind of being encouraged more and more. So it's not, medicine shouldn't be paternalistic, where a patient is just a passive receiver of whatever the doctor says. So it's a quite a tough topic, because on the one hand, patients are not doctors. When they see a doctor, they are in a very vulnerable state. But one of the speakers, for the documentary, Abdullah Al-Hassawi, he mentioned that he sees that patients could be kind of the last safety check in the whole medication or just procedure pathway, because yeah, but they would need to be a little bit more knowledgeable and empowered about the fact that they do have a voice, and that they can perhaps impact their whole treatment, which does not mean that they should know as much as doctors do. That's impossible, but just to kind of make them more
Sure.
engaged in their treatment. So I don't know, like, how do you see that is changing? Is it changing?
I think it is. From my teaching with the students, I'm always very keen to emphasise the importance of concordance when they're talking to patients about medicines. So rather than that kind of paternalistic, this is what you need to take, and it's important that you take it, and I'll see you next time. But to give them the facts, to give them the information about what the risks and benefits are, to have a discussion with them about what impact that might have on them, and to allow them to be part of that decision. And that's not just around starting medication, but also changing existing medication and being involved in decisions about stopping medication. So there was a study, and I can't remember the authors now, but it was a qualitative study looking into patients' thoughts about deprescribing, which we spoke about earlier. And there's you can still see some patients feel that doctor knows best, and therefore they're quite happy to passively allow doctors to make decisions. But there are others that absolutely want to understand, why is it you're changing that? Because if it was right before, why is it wrong now? So I think that culturally, people are starting to want to ask more questions. I guess people are a bit more consumer savvy anyway in a digital age, and I think that extends to healthcare. But I think that's kind of why that's the human contact part of healthcare is still so important. That the role of a healthcare professional as a communicator is still absolutely critical, to put things in terms that a patient can understand, but also try to empathise with the position that the patient's in. Going back to another aspect though around the importance in terms of patient involvement with safety, there's the importance. So when we admit patients that use insulin at home, we know that if they manage their own insulin at home, they're far more likely to be safe in hospital if we continue to allow them to do so in hospital. It's when we take that sort of self-actualization away from the patient, that errors start to be made. So we get incorrect prescriptions, we get incorrect administrations of insulin, the insulin's given at the wrong time, and then we get more episodes of hyper or hypoglycemia. So this is something that the National Patient Safety Agency, as was now NHS Improvement, is very keen to try to reinforce that we should empower patients who manage their own insulin at home to continue to do so long as it's safe, so long as they are well enough whilst they're in hospital, because they do know better frequently what suits them, rather than clinical staff that have no real background knowledge of the patient.
Speaking of patients taking medications on their own in the hospital setting, how does that impact the whole treatment in the hospital? On the one hand, you want to have everything under control, a clear picture of what the patient is taking, but is that even possible if a patient is taking 20 medications at home and then he's supposed to take those 20 medications on his own in the hospital and is potentially given by the nurse a few additional medications for the acute problem that he's hospitalized for? I imagine it's quite can you have an accurate picture of what the patient is actually getting?
It's really tricky. I don't think there's currently an easy solution. I guess we need to get to a point where technology will help us to deliver that. But say, for instance, patients with cystic fibrosis, they manage their medication at home frequently, and a significant part of their life is taken up by managing medicines, oral medications, some of which they need to take with every meal. Sometimes they're on insulin. Frequently they have nebulized medications, sometimes they have IV medications. So they're very experienced in managing their own medication at home. And it can be quite difficult to hand that responsibility over to nursing staff when they come into hospital, although maybe sometimes they may feel so unwell that actually they would prefer to do that. But I guess you also have to question, well, what do you gain by devolving that responsibility to a member of nursing staff? You can only control medication administration while the patient is in that acute setting. So, okay, yes, but you may have an acutely unwell person, and you need to try to keep things as controlled as possible. But that patient only spends a very small proportion of their life in hospital, and what they take at home isn't necessarily reflected in what you're going to see in a medication record in a hospital admission. So I guess in some ways the accuracy of that in some settings in hospital is perhaps maybe overstated, because it doesn't reflect what goes on in real life when the patient's at home. Clearly, if a patient is critically acutely unwell, we need to try to keep things as stable as possible. But I have mixed feelings about how vigorously we should chase the accuracy of that administration record. Clearly, we want to try to cut down the numbers of administration errors. You spoke about the vast number of medication errors that we see in the NHS, and a lot of those are administration rather than prescribing errors. We want to try to minimise those, but at the same time, we've also got to by disempowering patients, because we want to make sure we know exactly what's being taken, I think we perhaps give ourselves a false sense of security about what's going to happen when the patient goes home.
Yeah, it's one of the speakers that was talking about diabetes kind of very nicely explained, because blood sugar is, it has a very specific way of managing it, and is very dependent on a lot of factors related to stress, food, exercise. And when you get to the hospital setting, even if you're taking things the way that you did in the home setting, the environment is completely different than in the home setting, which makes kind of the whole medication management for a person with diabetes much more difficult.
I was going to say, just things like the fact that they're eating different food. Their meal times are different. They can't control when they're having their meals. They don't have the choice or range of food that they're eating at home. It has such a big impact also on on how they manage their diabetes. Their exercise is limited. It is a completely different setting, as you say.
One last question for you, and that is, when thinking about medication-related patient safety, reducing errors or adverse drug events due to medications, what comes to mind when thinking about the future? What are you looking forward to in terms of improvements that can be made in the field?
Going back to what we were saying earlier, I guess being able to kind of manage that tension between the likes of clinical decision support and AI flagging up issues, being able to manage that with still individualizing that around patient care. So I guess that my hope is that we can pick up on the potential for errors, but not necessarily take away the decision making from the individual professional.
Because that this happens to me sometimes. I say this is the last question, and then I think of 1,000 other things or topics that come to mind. So I guess one thing that I was kind of wondering was there's also the notion that culture around safety is very important when it comes to looking at medication safety in the hospital setting. So to which extent do you see that is one of the main factors that has a lot of room for improvements in hospitals, speaking generally again?
Definitely. I mean, I've had a little bit of involvement in some sort of human factors, team resource management type training, and the importance of being open to problems being highlighted. So trying to avoid hierarchy, enabling people to speak up, trying to learn from the more frequent no harm or low harm incidents rather than relying on just the really serious ones. These are all kind of still culturally difficult things to get across to prescribers. The incident reporting is still very much seen as I think by some individuals at least, as something you do when you either have an actual disaster or a near disaster, and you kind of miss a trick by relying on that. We do talk a lot about no blame culture. I still think that people have some hang-ups about that as an idea. But certainly looking at it from an electronic prescribing lead, it's much more useful to be able to have instances flagged up as incident reports when no harm happened to the patient. That's very powerful, and we're not looking to try to then apportion blame to individuals. It is about trying to improve systems, but also within the NHS there is a push to try to talk about safety too. So this is rather than focusing always on errors, to also focus on what's good, and learning from when things go well, and making sure that those kinds of practices are reinforced rather than always looking at just the negatives, because most of the time things do go right. And so it's important to learn the lessons of that rather than just focusing on when things go wrong.
Yeah, I guess that's definitely one of the messages, that not all errors are problematic in a sense that they cause patient harm. As mentioned before, 3 out of 4 errors are basically not either fatal or have long-term consequences. But it's still, I guess, because we're talking about human life, so any serious harm is just so much more horrifying, I guess, is one of the words that you could use. So, we definitely want to minimize the errors as much as possible.
Yeah, and it's getting that message across that actually, if we want to be able to do that, then we need to use as much learning opportunity as we can. And a lot of that arises from those no harm or low harm incidents. If we could learn the lessons from far more of those, then more of the serious harm incidents wouldn't happen in the first place, because we would have hopefully modified systems and practices to reduce the kind of risk associated with those.
Mm-hmm. Duncan, thank you for all the insight, and yeah, hopefully this documentary and this whole kind of series of discussions is going to raise some awareness about the topic, and make those that can make more impact think a little bit about what can be improved wherever they are, either a patient in a home setting or someone working in a hospital.
Okay, thanks, Tasha.